Yeah, so I wasn't sure whether the case was related. I thought maybe the case was going to have a personality disorder, but anyway, I'm here to talk about, when you have this co-occurrence of a substance use disorder and personality disorders. So I'm glad that I have a little bit more time than I expected because it's a little bit longer than 15 minutes, but here we go. So this is the accreditation statement. Our learning objectives. So by the end of this lecture, you should be able to identify what are some key diagnostic features of both antisocial and borderline personality disorder early in the course of treatment. So these two are two of the most common personality disorders that we see in the substance use population. So that's why I'm going to focus on those. Discuss some evidence-based treatment options for that comorbidity and be able to provide recommendations that are patient-centered, and then use specific strategies so that you can create a strong therapeutic relationship and ultimately encourage behavior change. So this is an overview. I always like to start with definitions so that we're all on the same page and we know what we're talking about. I'll talk briefly about the causes of the comorbidity of SUD and personality disorder. Also about the epidemiology, and then I'll jump straight into both antisocial and borderline personality disorder. So what are personality disorders? They are collections of traits that tend to be pretty inflexible and pervasive in nature. They usually have their onset in adolescence or early adulthood, and they tend to be stable over time. Some of them get better, but for the most part, they're pretty stable over time. And the important thing is that they lead to significant impairment, both to the individual who has the personality disorder and to the folks who interact with them. So there are three clusters. This is from the DSM-5, the Diagnostic and Statistical Manual that we use in psychiatry. So cluster A is paranoid, schizoid, and schizotypal. Cluster B, which is the cluster that we see the most in the SUD population, has antisocial, borderline, and also histrionic and narcissistic personality disorders. And cluster C is more of the anxious type, and there's avoidant, dependent, and obsessive compulsive personality disorder. This slide was in my deck, so I think I will leave it there. I think you all are familiar with the DSM-5 criteria for substance use disorders, so I won't say more about that. But we'll talk about the epidemiology of these disorders. So what's the prevalence of personality disorders? In the general population, what you'll find is it's about 10%, 10 to 15%. Within the substance use disorder population, though, the prevalence is much higher, and it's around 50%. So anywhere from 35 to about 75%. Again, antisocial and borderline are by far the most common. At least 1/4 of people seeking treatment for substance use disorder have antisocial personality disorder. I think the statistic is something like from 20 to 80%, so really high prevalence. As a general rule, the more severe the substance use disorder is, the more likely the person is to have a personality disorder. And then SUD prevalence, as you know, in the general population is about 17%. This is from the last data that we have from the National Survey of Drug Use and Health. In the personality disorder population, they have 5 times the risk for having an alcohol use disorder and 12 times the risk of having a drug use disorder. For borderline personality disorder, the prevalence of SUD is 22 to 78%. And for antisocial personality disorder, lifetime prevalence of an SUD is 80%. So a lot of comorbidity there. So what causes this comorbidity between SUD and personality disorder? There's 3 sort of main lines of thinking about this. The first one says that there was a pathological personality. There was a psychopathology in the personality that preceded the SUD. It didn't necessarily cause it, but it was there before the development of the substance use disorder. The second one says that there was the substance use disorder and trauma related to that and probably preceding that. And then that led in the future to the development of a personality disorder. And then the third one talks more about common biological factors coming together, and especially impulsivity, which is present in both SUD and personality disorder. And then those sort of common traits lead to the sort of co-development of both the personality and the substance use disorder. Of those 3, the first one is by far the one that has the most evidence. So the thinking is that people have the psychopathological personality traits to begin with, and then that predisposes them to the development of a substance use disorder. I won't go into this, but there's basically 3 developmental pathways. This is one line of research in terms of how that develops, but I won't go into that for the sake of time. So let's go straight into antisocial personality disorder. I'm not going to read through all of it, but I think it's important that we kind of touch on the main criteria. So antisocial personality disorder is, again, a pervasive pattern of disregard for and violation of the rights of others. It has to happen since the age of 15, and the criteria says you got to have at least 3 of the following 7. So the first one is a failure to conform to social norms, so unlawful behavior. And that for someone with a substance use disorder, it's important that it's not just related to the substance use disorder. So it's not just to buy drugs, say. It has to be present in other areas as well. The second one, deceitfulness, so repeated lying. These are folks who just tend to lie a lot. Impulsivity, irritability, or aggressiveness, as indicated by repeated physical fights. So the criteria, notice that they point to specific behaviors. So it's not just, traits or emotional, inclinations of the patient. It has to manifest in a specific behavior. Like in this case, it's not enough that your patient is just irritable or angry. They have to actually get into physical fights. Number 5 is disregard for the safety of themselves or others. They're irresponsible, so they usually have a hard time keeping a job, honoring financial obligations, paying things on time, paying debts, and things like that. They have a lack of remorse, so they tend to be sort of indifferent to the effects of their actions, especially hurtful actions on others. They kind of don't see that responsibility or role that they may have played in that. Another criteria is that they have to be at least 18 years of age, but there has to be evidence of conduct disorder with an onset before the age of 15. And this is something that you might have the diagnosis if they're coming from, I don't know, a child psychiatrist, but otherwise you can kind of get it by history. So they have to have had difficulty in several areas before the age of 15 that would probably have led to a diagnosis of conduct disorder if somebody had paid attention at the time. So again, it's a diagnosis of 18 and above, but there has to be evidence of conduct disorder before the age of 15. And then again, as in a lot of psychiatric illnesses, so this behavior that cannot happen exclusively during, say, a manic episode. It has to be more prevalent than that. So that's the criteria, but what are maybe some easier, more tangible signs that you might be dealing with someone with a personality disorder when you see them in the office, say? And these are folks who often present with certain characteristics. Like these are people who demand immediate results, right? So they walk into your office and they know what the plan is going to be, and they want this medication and they want you to do this and that, and they won't take anything else for an answer. And they want that prescription, usually alprazolam, you're right, or something like that, and they want it today, right? So you can't like think about it or ask for other information. So they want things now. They tend to blame others, especially when there's lack of progress or when treatment or progress is not going as they expected it would go. Again, sort of going back to the criteria, they have difficulty taking responsibility for their role in whatever is happening. They tend to be threatening when they are dissatisfied. And that can be, small things like I'll find another doctor, I'll go to a different clinic, or I'll talk to patient relations or your boss, or they can also threat your safety, right? So the threats have a range of acuity, I guess. And then this might be obvious, but these are patients who tend to evoke feelings of frustration and hopelessness in us, in the providers. And so this is going to be sort of a theme. It's important for you to kind of keep an eye on your own pulse and see what your reactions are to these patients. So if you're someone who usually doesn't get, extremely frustrated or hopeless or helpless when it comes to treating someone, if you're experiencing those feelings, pay attention to that, because it might be it might not be you. It might be something else going on in there, in that interaction. So illness course and prognosis for these folks. So people with antisocial personality disorder, just as people with borderline, as we'll see soon, tend to have both earlier onset and more severity of substance use problems. Their psychopathological burden is higher. So there's a lot of comorbidity with depression in this case, a third of patients, anxiety disorders, they're twice as likely as patients without a antisocial personality disorder to have an anxiety disorder, impulse control disorders, and also ADHD. They tend to have poor treatment response and outcome. But I want to take a moment here and say that these people can and do respond to treatment. They just tend to have a poor treatment response and outcome, but that doesn't mean that, we shouldn't treat them. As we just saw, the therapeutic relationship with them can be very challenging. There's non-adherence issues when they don't agree with the plan, or they initially agree, but then they do something else. They tend to have low intrinsic motivation for change. There's higher dropouts, so both from the patients who are firing the provider and the provider firing the patient. And they tend to have poor social functioning, more family, social, and legal problems. So what are some evidence-based treatments for this personality disorder and for the comorbidity? So as you probably know, there's no FDA-approved medications for any personality disorder. So the mainstay of treatment is always psychotherapy. There are 3 psychotherapies that have been specifically designed for that comorbidity of SUD and personality disorder, and those are DBT. So there's a special form of DBT that is called DBT-SUD. Another therapy called dual focus schema therapy that also focuses on both disorders. And then the third one is more like psychodynamic, and it's called dynamic deconstructive psychotherapy, or DDP. And then CBT, there's studies of CBT, like in a test, CBT works for everything pretty much. And so CBT has also shown efficacy. And then I just found one randomized controlled trial specifically for for antisocial personality disorder and SUD that used psychoeducation, and that had some moderate size effects. So in terms of pharmacotherapy, like I said, no FDA-approved medications, but you can, of course, treat the comorbidity, right? And like we said, antisocial personality disorder is highly comorbid with other psychiatric disorders. So if the comorbidity is anxiety, if it's an anxiety disorder, the recommendation is to avoid benzodiazepines and to start instead with SSRIs or SNRIs or Buspar, trazodone, valproic acid, gabapentin, second-generation antipsychotics like olanzapine or quetiapine, or Abilify or aripiprazole have all been tested in this population. If the co-occurring disorder is ADHD, sort of the same as we would do for anyone with a substance use disorder, usually, not always, but usually we might start with a non-stimulant medication and then consider using the slow release, so extended release forms of stimulants as opposed to the immediate release. Now, what I wanted to say, I'll just go back here. These psychotherapies, they're pretty specialized. And the reality is that, for example, I don't have access to them here. I have access to DBT, but not to DBT for SUD specifically. So the chances that you're going to have access to any of these in a primary care setting are slim. And so if you're not going to be able to provide that, and you're not necessarily going to treat the personality disorder pharmacologically, then what can you do? What are some things you can do in your interaction with these folks to improve their chances of behavior change and just doing better in treatment in general? So number one, it might sound obvious, but don't take it personally. And that's why I think it's critical that you are able to identify that this could be a personality disorder as early as you can, because that will prevent you from getting too emotionally tangled and really taking it personally, like this is about you. This is not about you. This is a personality disorder and it's on the patient, and you need to recognize that and behave accordingly. In the case of ASPD, I mean, for all patients, right? For these folks in particular, it can be very helpful to intentionally work on developing empathy for what they're going through. So look for some strengths, right? I'm sure they gotta have some strength. And then the other thing that can help is reflecting on what these people have gone through. Um, there's usually a history of trauma, and so these people have gone through a lot in the majority of cases. And so if you can use any of that to develop any amount of empathy, that will help the therapeutic alliance. Number three is to praise rather than criticize. So these people in particular, they're very sensitive to that and they tend to respond better to praise. And so find things that they're doing well. They don't tend to do well with criticism. They get angry. They just kind of don't get it. Again, they have a very hard time accepting responsibility. And so praise works a lot better than criticism. Set limits, right? Set boundaries. So same for borderline. It's important to be consistent, to be reliable, to explain what the contingencies of treatment are, what the rules of the clinic are, what the expectations are. And then use objective sources of information. So again, it's one of the criteria that these people just tend to lie a lot. And so don't rely on self-report only. Do urine drug screens or labs and rely on collateral if you have access to that, whether that's from family members or sometimes a parole officer, probation officer, whatever you have access to. In addition, of course, to the patient report, we're not like invalidating their report at all, but just check your facts as much as you can. Use a team approach in treatment. If you're able to offer psychotherapy and if they're willing to engage in that, that can be very helpful. But also just check in with other people on the team, nurses, whoever interacts with them, just to check in and see how things are going, because people with personality disorders in general can be tricky to manage, and sometimes it's good to check in with a colleague to see, what about this? Are you getting the same impression than I am, and things like that. And then take care of yourself. This also might sound obvious, but the more you take care of yourself, the better you're going to be able to take care of the emotions that come up during that encounter. So there's a lot of in psychiatry we call countertransference. So the emotions that the patient elicits when we are in that interaction. That can be sort of your compass, right? So if you see a lot of emotions coming up, again, use that as information. But the more you take care of yourself, the more you're going to be able to respond rather than react to those emotions when they arise. Okay, so moving on to borderline personality disorder. So this again is from the DSM-5, and borderline is a pervasive pattern of instability, that's the main word, in interpersonal relationships, self-image, and affect, so emotional instability, and also marked impulsivity. It begins, like we said, in early adulthood, and it can present in a variety of contexts, and for the criteria, you need 5 or more of the following 9. Number 1 is fear of abandonment. So these people, they go to great lengths to avoid being abandoned. So you'll see this in different relationships, a lot of times romantic relationships, but also family relationships. That's sort of like a really crucial criteria for the diagnosis. Unstable and intense interpersonal relationships, and they alternate between extremes of idealization and devaluation. So sometimes we call that splitting. Identity disturbance. So these folks have a very sort of flimsy, fragile sense of self. They're very impulsive, and that has to manifest in at least 2 different areas. So that can include spending money, sex, substance use, driving, and binge eating. Recurrent suicidal behavior, suicidal gestures or threats, or self-mutilating behavior like cutting, burning, headbanging. Marked reactivity of mood there. So that's the emotional instability. And a lot of people with borderline personality disorder are misdiagnosed with bipolar disorder because they say they have mood swings, right? But the mood swings in borderline personality disorder tend to be much more rapid than in bipolar disorder. Now, as we'll see, they can coexist, right? So you can have someone who has both borderline and bipolar, but it's useful to differentiate those two. These folks have chronic feelings of emptiness, and then anger or difficulty controlling anger. Sometimes they have temper tantrums, and you'll see this in adults. And then the last one, number 9, is the transient, usually stress related. So there's usually a trigger, but they can develop paranoid ideation or dissociation symptoms. And this happens especially in folks with a history of trauma, which is very, very common in people with borderline personality disorder. So yeah, five or more of those 9. But again, more in your day-to-day, what are some signs that you might be dealing with someone with a borderline personality disorder? So that patient is a patient who's frequently hostile, angry, or suicidal. And they tend to evoke very different reactions from different staff members. Again, this is what we call splitting. So sometimes you, the main provider, maybe might be the chosen one, and you're the best doctor I've ever met, and I can't believe you understand me like no one else. Sort of really excessive praise. But then maybe with someone else, like a nurse or a front desk staff, they're acting in a very different way, or vice versa, right? Maybe sometimes you get to be the evil person, and then that changes also from interaction to interaction. So this is the stuff where you don't take it personally, because you're gonna go like up and down, in their in their hierarchy all the time. These patients tend to take a lot more time in team discussions than other patients. So say, you're running through the list of patients in the morning with your team, and you're just, going through the list, no problem. And then you get to this patient and, it's been like 20 minutes and you're still talking about this patient, and people have different opinions, and, you're not sure what to do. That should be a sign that there's something else going on here. This I said before, sort of the excessive praise, that is classic. I didn't put it in the slide, but now that we have the chat on Epic, if you see excessively long messages on caps, it's not DSM-5 criteria, but that should also be a sign that there's there might be something going on here. And just like with folks with antisocial personality disorder, these individuals can also evoke feelings of frustration, anger, and helplessness. So again, pay attention to that, to your emotional reaction in that patient encounter. Illness course and prognosis is pretty much, there's a lot of overlap with antisocial. In terms of co-occurring disorders for people with borderline, it often co-occurs with depression, like I said, bipolar, anxiety, and PTSD. Again, the trauma is probably the most, I don't have the exact numbers, but it's probably the most prevalent. So if someone has borderline personality disorder, you absolutely have to ask. It will probably come up, but you absolutely have to ask about a history of trauma. The one thing that's sort of unique for borderline is this last point here of increased risk for self-harm, suicide, and other self-damaging behaviors. And this, you have to be really careful, even if you're not, even if you're primary care doc and not directly managing the borderline, but these folks present with suicidal ideation all the time, right? And sometimes you can get desensitized to that. And it's true that, most of the times they attempt and they cut and they self-harm and they don't die, but people with borderline personality disorder do die by suicide. And so we need to take that very seriously, no matter how frequently they present with symptoms like that. Evidence-based treatment, again, mainstay of treatment is psychotherapy. And there's the 3 psychotherapies that I mentioned before that were developed for both a substance use disorder and a personality disorder. DBT in particular was developed for borderline personality disorder. And then since it's been so successful that it's been also tested for antisocial personality disorder, but it was originally developed for borderline. So that's, by far sort of the gold standard. There's also transference-focused therapy and interpersonal therapy, which could be helpful. But again, these are, unfortunately, at this point, unlikely to be available, especially in the primary care setting. CBT, it is, of course, but not so much the others. In terms of pharmacotherapy, as always, try to identify and treat any co-occurring disorders. So in this case, like I said, depression, bipolar, anxiety, and PTSD are the most prevalent. Treat the substance use disorder with medications when it's available, of course, like for alcohol and opioids. And then all of these medications have been studied for BPD. So antidepressants, anticonvulsant mood stabilizers, like lamotrigine is one that I use a lot for people with borderline, and atypical antipsychotics, like we said before. Those all have been studied in borderline and have some degree of evidence. And then there's some sort of guiding principles for prescribing for these patients. Because of that high prevalence of suicide risk behaviors and self-harm, try to use medications that have very little to no lethal potential. And then when you prescribe, don't prescribe too much. Don't prescribe, 90 days with 4 refills. Prescribe maybe a month, sometimes 2 weeks, sometimes 1 week, depending on what's going on. So make it, reduce the potential harm from overdose. Simplify the regimen, avoid overprescribing. This applies to every patient in every specialty, I guess, but particularly for these folks. And prescribe at maximally effective doses to speed clinical improvement. So you don't want to waste your time. These people are all frequently in crises. And so you don't want to waste your time kind of, titrating up the antidepressants. Like if you know that they need at least a dose of 40 milligrams of fluoxetine, go there and go there fast. Don't start with, 10 and kind of hang out there for 6 weeks. Go to the maximally effective dose as fast as you can. This, I thought it was kind of curious. There's a trial of ear acupuncture for borderline personality disorder and tobacco use disorder. So that's kind of cool. And again, what are some strategies in which you can that you can use to skillfully engage with these people? Number one, again, don't take it personally. Recognize it for what it is, and don't take it personally. This is not about you. And that's really easier said than done. So I'll just say that. With this population in particular, building trust is very important. So these are folks who are very sensitive to interpersonal issues. And so if you're not being authentic, if you're being kind of cagey, they're going to pick up on that right away. So be transparent and totally honest. And as with antisocial, use very clear and consistent communication. Number 3 is an important one. Validate what they're going through, validate their feelings. So people with borderline personality disorder were often raised in what we call invalidating environments. It's not uncommon for their parents, usually their mothers, because BPD is more prevalent in women, to have had or to have borderline personality themselves. And so it's important that you go out of your way to expressly validate what they're bringing to the session. Set clear boundaries and assert yourself and your role. Have a clear structured treatment and in the case of borderline, a crisis management plan. So DBT has a whole section on what they call a hierarchy of treatment targets. So they address symptoms. These people come to the office and they have like a million things going on at the same time. And you're like, well, where do I start? There's a hierarchy of treatment in which the first thing you need to address is life-threatening behaviors like suicidal or self-harming behavior. That's the first thing you address. Then you go to address behaviors that interfere with success in treatment, and then quality of life things. So there's always that way of prioritizing what to take care of. Here, even more so than for antisocial, use a team approach. So DBT is very intentional and heavy on that, the team approach. So especially if you're not a psychiatrist and not a specialist, seek supervision or discussion, kind of like what we're doing here. I realize that we're out of time, but I'm almost done. So number 7, take care of yourself, just like with antisocial. These are patients who, if you see a lot of them, they tend to increase your chances of burnout. So really take care of yourself. So conclusions, personality disorders are very common among people with SUDs. They add a significant level of complexity to cases that are already complex. Individuals with this comorbidity can and do recover with treatment. So even though it's difficult, don't give up. It's important to recognize the personality disorder early in the course of treatment. There are specific strategies that can help you work with these patients more effectively. And then again, it's important to learn to manage your own reactions and behaviors and to seek consultation when needed. So I think that's it. Sorry to have run over a couple of minutes.